Hello, welcome to Living and Dying, the show that brings you news and information about the people and the activities of Brattleboro Area Hospice. My name is Richard Ewald, and I'm a hospice volunteer. Joining us today at the BCTV studios are Ryan Murphy, volunteer coordinator for Brattleboro Area Hospice, and Agnes Mikianitz, who is a nurse practitioner for oncology at Brattleboro Memorial Hospital. Welcome to you both.
Thanks.
Thank you. It's good to be here.
Ryan, we're here to talk today about what's known in the hospice program as the Pathways program.
Mm-hmm.
And this is different from typical hospice in many different ways. And I think it would help us get a sense of what those differences are. If you could sort of take us back to the beginning of Brattleboro Area Hospice.
Sure.
Tell us where, remind us where it originated and how,
Mm-hmm.
and for what purpose.
The Brattleboro Area Hospice, Rich, is what's sometimes referred to as freestanding hospice, in that it's a non-medical hospice. And the services are delivered through volunteers. And it began in this area in 1979. So it predates the medical hospice programs that people know of now and that serve them at the end of life. It was just a group of people in the community who saw a need and wanted to see what they could do about it. There were some doctors involved, but mostly it was just folks of the community. So they developed a training and began offering it to folks, and it continues today to be the model we use. It's grown and been developed, but it's an 11-week course, 3 hours each week. People come and learn about how to care for people at the end of their life. We collaborate with medical hospices, but as I say, we're freestanding. And there aren't many more in the country left that are structured like we are. So we feel very good about the fact that we're still here and quite healthy. The Pathways Support Program is about 12 years old now. And again, it was people within the Brattleboro Area Hospice and the community who saw a need for folks who were facing potentially terminal illnesses, likely terminal, but that they still wanted to pursue treatment, and hopefully they had up to 2 years to live. So that's a major difference between a typical hospice program, which means that a person has to have a prognosis at 6 months or less and make this sometimes very difficult decision to not pursue curative treatment. So those are the things that were the impetus to begin the Pathways program. And the volunteer support we offer, which is emotional and practical, is virtually the same across the programs. And oftentimes we will begin to see someone when, for example, Agnes might call with a referral, and they will in fact then eventually go on to a medical hospice program, and we're able to continue with them to the end of their life. So that's basically how it got started and still functions today. And it's also important to note that anyone can call with a referral, an individual, a family member, and that we respond to all inquiries.
So I'm hearing some fundamental differences. One is the 6 months for a typical hospice versus up to 2 years.
Mm-hmm. That's a big one.
And you also use the word curative compared to palliative care. So,
Well, it can be both. I mean,
it can be
simultaneously. Oh, sure.
So what does that look like from the oncologist's perspective then?
So if you are taking care of a patient's entire case, you look at the social structure, you look at what the goals of the care are, and you look at sort of the prognosis. And then as the nurse practitioner, put together a plan that meets the family's need. So you may have a patient who has stage 3 or 4 lung cancer, and when I meet them, even if they are trying to for example, go for a chemotherapy regimen that maybe will offer them a 20% possibility of cure, they are still as ill and require as much support as a patient who may be in the last 6 months of their lives. So pragmatically, the needs are very similar for what we try and offer patients. So that's why I use Brattleboro Hospice, because I'll need supports for a patient regardless, and the medical piece is something that I can handle with the physicians. Mm-hmm. If there are tasks that are required from the visiting nurses, I can handle that, but it's very helpful regardless of whether or not I know this patient has a 2-month, 6-month, 2-year prognosis. I still sort of need the same types of social supports. Mm-hmm. So getting Brattleboro Hospice involved when I have a patient who's starting into that trajectory is helpful. And as long as I explain to the coordinators the sort of the underlying prognosis and treatment plan, then they will try and tailor around that.
And what does that mean for you, Ryan, to tailor volunteers to a different timeline?
Well, it does present some of its challenges. I think it would be helpful for the viewers to know also that because Brattleboro Area Hospice is not tied to insurances, that's how we're able to offer this program. I mean, if insurance were compensating for programs, Agnes would be referring that much earlier, but they do not, so we're able to do that. The challenge is most people enter into the world of hospice as volunteers thinking they're going to be journeying, if you will, with people in the very last part of their life. Obviously, in the Pathways program, there has to be some adjustment to that because they could be involved for a full 2 years, and there have been times when everything looked right to go for the Pathways program, people didn't die, and yet the need remained the same. So they were very extended, and that's when volunteers really need to know they can come and talk, or they can rotate off a case. So there's some significant differences in how that works, and we need to be careful with folks when we start to let them know that, you know, things may change. You may thankfully improve, in which case we would discontinue our services for a period of time, perhaps, or even longer. So it's the mindset of the volunteer. It's the ability. When I not too long ago was volunteering, I was with a fellow for 24 months, and it was a great experience. It was hugely rich because one of the things, and one of the reasons it's so great that Agnes thinks of us when she does, it gives us an opportunity to develop relationship. And one of the real challenges in the overall hospice picture is if you look at the statistics, the mean amount of time for a person to be on hospice care, you would know better than I, it's like hours when you factor it all in. I mean, so timely referrals are always a challenge for us. And with people like Agnes who are aware of our Pathways program and know they just need to pick up the phone and call and we'll do whatever we can, it really helps to have that opportunity to develop relationship.
It strikes me that there's said to be a stigma about either oneself entering into a hospice program or having one of your family members start receiving hospice volunteers. The stigma that you're giving up, you know, that it's sort of the end, and there's a surrendering in some way that people don't like to feel that they're part of. This sounds very different in that you can transit, if everything else qualifies for this program, you're not really blocked by that stigma, it sounds like. Is that true?
I think it's true, and I think you have to make sure you explain that up front so that when he calls from the hospice program,
Right.
that I haven't thought that they were dying and not told them, for example. So I have to be very, very clear on what I think the goals are and explain to them that advanced cancer or cancer that has a significant symptom burden to me looks the same as a hospice patient's, you know, and that it doesn't in any way mean that I think you're going to die within weeks. And I'll say that up front.
Yeah.
Yeah, and it's a good point because, you know, even when I go out and meet someone, we are the Brattleboro Area Hospice. And so, you know, you need to take pains to be very clear that, yes, that's who we are, but we also have this other program, and explain, as Agnes said, that, you know, it seems like you're at a point and your level of need is such that we can be of some support here. And usually it works pretty well. But it can be a challenge, just because of the name.
Yeah. So Agnes, as you're looking at a patient in totality, what are the elements that you look at? I think you mentioned them very briefly, but they sort of went by me in a hurry. What parts of the picture do you look at that makes it clear that hospice would be really appropriate in this situation? And when does it seem like it's not really called for or needed?
I mean, a lot of what you do as a nurse is you look at what we call functional status. So how old is the patient? How sick are they? Are they in bed more than 50% of the time? What does their family structure look like? So I can have a patient, and for example, they could be 65 years old, but if they are diagnosed with what we call small cell lung cancer, I know statistically that only 10% of them will be alive in 3 years across the board. If I have a patient who already has emphysema, is already on oxygen, already has, only has 1 or 2 family members there to support them, or has a fair amount of fear and anxiety, all those things are at play. And essentially I try and imagine if I was a person's family member or their nurse in their house for 24/7, how much one-to-one attention would that individual need. And I know, having done this job for 15 years, that family members burn out, and if you walk this through, that if you don't start putting those supports in early, your patients will often just sort of hit a critical mass where they develop symptoms that you didn't take care of and they're in the emergency room, or their family members come to you and they're in tears because they are burnt out and they've been with their loved ones for 6 weeks. So often I'll talk to a patient and say, you know what, I don't know that you need the Pathways program or that you need hospice per se for your coping needs, but I know your wife does because I'm observing her, or I know what she is doing because I've done that for a living, and sometimes I'll just talk as the patient's family's advocate, which often will be a strong billing point and is helpful, because once I have Ryan in the door and they get to meet the coordinators and the individuals from Brattleboro Hospice, then things are almost always go very smoothly. So it's more a function of getting them in the door, but also making that assessment from a nursing perspective.
So by family structure, you're referring to that whole surround, or how many people are here, are there the people who are going to actually be taking care of the
Is it
patient?
you and your spouse, or is it you and your spouse and 5 kids that live in the area? And so I can say who's getting groceries every day. And they'll have some patients who have a very strong family structure, and they'll have a nurse within 5 miles who's a relative, and they'll say, no, I don't really need that because I have all the support I need. And I'll have other individuals who are really, really lacking and are possibly facing nursing home institutionalization if we don't sort of start taking care of the caregivers.
I think, if I may, Richard, the fact that we're non-medical folks, I think, also helps the entree a little bit. They're not carrying that burden of a terminal diagnosis. I mean, it's there, but it's much more tamped down than if they were looking at 6 months or less.
And since you're already there, you're already in the door, so to speak, and presumably as a trusted person, your recommendation for hospice overcomes another one of the stigmas of getting entree to people who could use the services, which is these strangers coming into my house, who are they, can I trust them? In this case, you're saying, actually, no, this would be a good thing.
Yeah.
Oh, that's invaluable.
Yeah.
I mean, without that, a lot of the Pathways clients wouldn't be part of our census, because Agnes does represent us in a way that's accurate and supportive and encouraging.
And I'll bet that observation that if I'm laying in the bed and you're offering a service, I might say, no, I don't need it. But if you're saying, you know what, your wife needs it, your spouse needs it, I would say, oh, okay, yep, definitely. What was I thinking?
That happens a lot.
Yeah.
I think when you're faced with end of life, this culture does not equip us well to look at it objectively. And so patients often will have this magical thinking. It's denial is helpful in some ways, but in other ways it's not helpful. So they feel that, yes, I have this illness, but I will be physically well until I just suddenly die one day. And someone needs to talk about, no, you'll be in bed maybe for days or weeks. Who is going to get you the cup of coffee? Who is going to help you out to the bed? How is your wife going to go shopping if you're in bed? And just start talking about those practical needs, because otherwise those stressors just build up and it becomes a critical mass. And it's much better for everyone involved to start talking about it up front and talking about supports, as opposed to waiting for things to fall apart and us having a family meeting in the hospital and look at why did this happen, and then nobody, and there's less. It's just a better experience for everyone, and no one's failed.
Right.
And
as long as, I mean, we before the camera started rolling, we were talking about the traditional doctor's approach to medicine, which is to dictate from on high what is best, and they never want to give up. They don't want to give up, and that's a different way to look at it.
Well, certainly one of our goals and the goals of hospice is to do whatever we can to ensure the highest quality of life for how much time that you do have. And for someone to be able to stay in their home, which is one of the things that is very high on our priority list and on Agnes's too, is that's a huge indicator of quality of life, obviously. And sometimes it would be virtually impossible for caregivers to have someone stay in the home safely unless they have some of the kinds of help that we're able to provide. And it would probably be a good time to mention that there is a caregiver support group at BMH, Brattleboro Memorial Hospital, that meets twice a month on the second and fourth Tuesdays at 4:30 until 6 o'clock. So I just want to be sure the viewers are aware of that. And that's another way that we can try to provide some support for caregivers. Because if people haven't been through this before, it's my experience that they just, most of the time, have no way of knowing what they're going to need and what kind of challenges they're going to be facing.
And what could they expect to happen at this support group?
People share what their experiences are, and it's a very informal kind of, how should I say it, caregivers supporting caregivers, I guess. Some of them have very similar situations. If they have a parent with dementia who they're taking care of in their home, for example, they'll share stories. They'll kind of group think possible resources or things to try. They'll share information. But mostly I think it's just going to a gathering of other people who are facing very similar challenges in their life and who can empathize.
Which sounds very useful. We've talked already about the impact of a 2-year relationship on the organization's use of its volunteers. And this is a recognition that it's a different experience for caregivers the longer it goes on, too.
Yeah, and oftentimes our caregivers they're pragmatic and flexible, and can do some, as we said before the show started, walk the dog, call beforehand, do you need anything from the store, that kind of thing. But the majority of their time is spent providing respite to the caregiver so that the caregiver can take care of necessities they may need to do, like Agnes said, go to the store, or just have some downtime. Because depending on the situation, caregiving can be very dangerous in itself. I know that there's people that I've met who have had some very serious health issues because of sleep deprivation, for example. So they really, there's a lot of levels and different category of need. But yeah, they need to get their needs met as well, or they're not going to be able to meet the needs of the person they love and are caring for.
I'm realizing that I was probably painting with a pretty broad brush when I talked about doctors who did not accept.
Well, you said traditionally.
Well,
I think that helps.
What has been your experience, Ryan, Brattleboro Area Hospice's experience with doctors in and around Brattleboro?
Well, I don't know how much I can say about that.
Well, I kind of guessing there's been sort of at least a slow cultural shift in it a little bit.
Oh, there is, but, and I have to speak broadly. I mean, there's some wonderful, it's just like anything else. You meet some of the finest people you're ever going to meet, and then you meet people that have room for growth. But by and large, it's a caring community, caring population who are striving to do the very best they can. But you're right, there is an ongoing challenge, I'd say, for all of us to learn more about optimal care at end of life. We were talking earlier that, communicating effectively, bringing compassion, really drawing someone out, again, if they've not been through it before, knowing which questions are going to be the most helpful to be asking, and to be sure that they understand what their decision means, what the implications of taking one course or another may be. That's one of the junctures where it's very important that communication is as effective as it possibly can be, and that goes across, that's not just doctors, that's everybody who's involved in end-of-life situations. Because information and reflection and support are all really essential to helping people to get the most out of what time they do have still to live.
I guess we all hope for honesty from our medical folks, along with a little bit of caring and tenderness when the news is a little bit difficult to understand and consider what all the choices are.
Well, I think, and again, we were talking some of this earlier, we are on a path and things are evolving, I would say. And, you know, so doctors are essential in our care most of the time, and I think they all do the best they can, again. But we're on a path of more options, more awareness of the implications, again, of the decisions people make. And I think doctors are also just part of that. They're growing as well as the rest of us.
Well, it is a different approach to both acknowledge that sort of the end is near, we've got a prognosis here, this is honestly the prognosis, and we can continue to do some curative treatment and see what happens.
Yeah. I'd like to think of...
go into it with your eyes open. Is that sort of what it is?
I think there's 40 different types of, I'm just speaking towards cancer, there's 40 different types of cancer.
40.
40. And there's been a significant amount of progress in the treatment of cancer. The curing of cancer, maybe less so, but we have a lot of different agents that are now controlling cancer. So there's been a paradigm shift, I think, in palliative care and understanding that patients often may not survive, and we are as responsible for communicating that or taking care of them through the trajectory. But there's also, if a patient wasn't cured of their disease, for example, in 6 months to a year, they often would die because there wasn't a lot of options. There are now targeted therapies that find the molecular Achilles heel of certain cancers and won't necessarily make the tumor shrink, but won't allow it to grow, and the tumor may be static, for example, for years. So just for example, renal cell cancer wasn't a lot of options 7, 8 years ago for chemotherapy. It was a pretty dismal prognosis, generally 9 months to 12 months across the board, because it just really wasn't a lot you could do. There are 4 or 5 different targeted agents, which are often in pill form, that if you respond, I have patients that are living 3 or 4 years and living well, mowing the lawn, going grocery shopping, but have to adjust to the fact that they have an incurable disease, which is, you know, definitely a paradigm shift in how you view the world and what you find as your priorities.
And I
So
think
So you have to, in college,
Yeah.
learn to have this dialogue, because I don't know which one of the 30% of those patients are going to respond. So you need to have the dialogue about what are we going to do if this doesn't work,
Right.
because I don't know which one of the individuals sitting in front of me is going to be that 30%. So we can't presume that, you know, everyone's going to be the responder. But you can offer hope, but it has changed the way we approach the disease in general.
And you'll frequently hear people say that we're in a kind of new era where the types of things that would bring about someone's death in the not too distant past have now been effectively treated, and so we're living longer, and we're living with more serious illnesses longer. So that's another, I think, important to mention to what we're facing as we attempt to, really as a society, figure out what we're doing about this end-of-life thing. And of course, it can be very taboo. You know, our culture in particularly does not have a good track record of recognizing that the death rate is still 100%. And, you know, that's just the way it is. So we are doing things like have just begun to do what we call death cafes, where we're just offering them to the community for people to come together informally and in small groups, talk to other members of the community about all different aspects of end of life. And I think that's a healthy thing.
So this is death and dying and dessert. Sort of all together.
We do have desserts at these, yes. Yes.
So it's an informal way. I mean,
It's very
just
informal.
Get it
yeah,
out, get it out.
It's got an interesting background. We'll probably do a show about it one of these days. But yeah, it's fairly new in America. It started in Switzerland and then went to England. But anyway, Death Cafes. It's another part of our mission, which is to help people have good, effective, healthy conversations around the fact that we're all going to die, and what are some of the things that are important to us when that begins to happen to us. And it can make a big, big difference. I mean, we mentioned before, relationships, having people come into your life. And doing the work we do is always a privilege. To allow people, or to allow strangers to come into your home and meet you for the first time, and the context of that meeting is you're approaching the end of your life. I mean, that is a rare opportunity to get close to someone. And it's those relationships and those opportunities to provide just general human interactive care that really are at the core of what we try to do.
And
that was a ramble, sorry.
No, that was a good answer. And the typical, as we used the word before, the typical hospice relationship and time period is very short. Life can be extended, and a patient's well-being can improve to the point where I called you in a year ago, hospice, thank you very much for coming and supporting my family through this. But guess what? I'm out of bed and I'm walking around and I can get to the store. Thank you very much. If I get worse again, I'll give you another call,
exactly.
so to speak.
Exactly.
And then so you get to have that conversation as well.
And it's just healthy. You know, we're a friend of mine says, you know, we're hardwired to be in relationship, right? And I think that's true. And it's an opportunity to experience connectedness as people at some very deep and important levels. And the sooner we get connected, the more we have that opportunity, which is why pathways can be invaluable.
You used the word tamped down, I think, at one point to refer to sort of the difference in, maybe it's an emotional climate or something, between the 6-month versus the 2-year prognosis. How does that actually exist? Does that difference really exist? I mean, these are both very, very stressful situations. But in terms of the very short term
versus the longer opportunity.
Is there I'm struggling to see.
Well, I think it's a more intense experience for a patient. If I call them and, you know, or I've just met them, but I know they have disease in the brain, I know that they are deteriorating, and I'll sometimes have to be very clear going, I know that you're deteriorating, we have to work on keeping your symptoms under control. This is going to be an intense period for all family members involved, and I'll have Brattleboro Hospice in, I'll have a medical hospice program in there, but we'll be talking about what does your terminal event look like? Do I expect you to be struggling to breathe? If I do, you're going to need oxygen. You're going to need people around you. We're going to be talking about medications to blunt those sensations. So that's a much more intense experience than you have X cancer. I don't think it's curable. I do think you're going to have supports that you're going to need, medical and or psychosocial, and we'll have a better sense 6 to 12 months how this is going to play out. And maybe you'll transition out of pathways, maybe you'll transition to hospice. And that is a less intense conversation than ones where I call Ryan, look, I need you in the house yesterday.
Yeah, and that happens too. But yeah, I mean, it's a journey, and it's a continuum of degrees of intensity of experience and feelings and life.
Well, we've just about reached the end of this journey of this show.
Good, thanks.
I want to thank you both for coming in, Ryan, Agnes.
Thank you.
And it's another reminder that Brattleboro Area Hospice Services are available to a very broad range of folks, no matter what your medical situation, whether it's a 6-month prognosis or a 2-year prognosis. Anyone in the family can call and start meeting all the folks at this wonderful organization, BrattleboroAreaHospice.org, 257-0775 for information about any of these things we've been talking about. Thank you for joining us. Again, my name is Richard Ewald. I'm a hospice volunteer for Brattleboro Area Hospice. Thank you very much.